So I might move on to the next speaker, which is Amy Legg. So Amy is a fellow at the Menzies School of Health Research at the Darwin University. She's also worked with Queensland's statewide AMS program and is a pharmacist who works at the Royal Brisbane and Women's Hospital. She's an experienced clinical pharmacist in infectious diseases and antimicrobial stewardship, and in intensive care. She does a lot of good work there as well. Her research interests include urinary biomarkers for the diagnosis of acute kidney injury, antimicrobial TDM to ensure efficacy and safety. And recently, Amy was working with us quite closely at the Erston Infectious Disease Institute as a pharmacy research fellow, where her focus was on developing guidelines for therapeutic drug monitoring. Amy is live with us, so it's great to have her here. Thank you.
Thanks. That was a masterful note there. Just really appreciate you sharing those slides. That's the hardest bit. I slightly got the title of the talk role. But anyway, I'm Amy Legg. I'll be talking about dosing simulation just in terms of several case studies. I'm also really appreciative of the invitation to speak. Feeling very honoured to be presenting with the other people today. 2 excellent talks already and 2 excellent talks to go, I guess. The remaining 2 speakers are Mad Keen Bronco supporters, so that's always very reassuring. Pick that one out and use I and I would just like to reiterate Oz's comments to acknowledge that we stand today in Meanjin, Brisbane, that lands of the Turrbal and Yagara people. And I pay my respects to elders, past and present, and I pay my respects to any Aboriginal and Torres Strait Islander people who might be on the call tonight or listening to this talk at any time. Okay, so I'm just going to go through a series of case studies where I've used dosing software to look good and drive patient care. So the first patient that I've got here is a current inpatient in our intensive care unit, Mr. TD. He's a 31-year-old male who had a motor vehicle accident, multi-trauma. It was a very serious accident. He was in a truck and hit the car. He had significant injuries at the scene, and I think someone has quite gracefully written that he had obvious bilateral lower limb deformities. In terms of the orthopedic review, he had bilateral distal radial fractures. He had a right neck and femur fracture. These communicated severely impacted femoral shaft fractures, injuries to his ankles and throughout his foot on both the right and the left side. And a further complicating situation, on a CT, he had some areas of what seems like poor circulation below the level of the ankles. So quite significant injuries, damage to the skin and soft tissues around it, and then also with a decrease in blood flow to the precoce. So this was a man who first came to us about 3 weeks ago and has had many issues with infection. So at various points, both lower limbs have appeared worrisome for infection. The surgeons have taken him back to theatre multiple times with increasing areas of debridement and amputation, and he's ended up with bilateral below-knee amputations. He's had issues with wounds, but he's also had issues with bone samples and the 2 stumps that he now has. And he's had multiple microbiological samples. So he's had things in his chest. He's had probably contaminants in his blood. But what we've been worried about is really these legs, the operative samples and ongoing. And so what we were treating was a bone specimen from his right heel, which had scant leukocytes, grew with 2+ of Staphylococcus multifilium, eventually grew a Staphylococcus epidermidis, and it also grew a Bacillus cereus. So this man is 31. He weighs 154 kilos. He's 200 centimeters tall, and he has a creatinine of 62 micromoles per liter. So he's a pharmacokinetically unique patient, and he's also in the ICU very unwell, so we want to make sure we're giving him the optimal dose of drug. So the ICU pharmacist initially recommended 1 gram IV 6 hours. He's a 30-minute infusion, which I thought was a very nice dose. It's obviously going to need more than 1 gram 8 hourly. So going to 6 hourly to optimize the type of the MIC, I thought initially was a really great idea. Unfortunately, we did a trough concentration. We'd love to be above 2 to show 100% free of MIC and a concentration of 0.6. So I'm similarly to 4 do dosing simulations through IDODS. And so I'll just talk you through this graph here. So I've put in his details, put in when his doses were, his creatinine and his first concentration to do a Bayesian model. And you can see here he's got very low concentration. So he's got quite low peaks of meropenem even, and he's well and truly clearing the meropenem by the end of the dosing interval at 1 gram 6 hourly. When the level came back at 0.6, the intensivist thought, okay, well, we should give more. So they gave 2 grams 8 hourly to make really no difference to the exposure time at the time above the MIC there. So at 1 gram IV 6 hourly added an infusion, he was only above the MIC for about 30% of the dosing interval, and increasing it to 2 grams 8 hourly as a push only increased the time above the MIC to 32%. So relatively ineffective there, even though it feels like we're giving more to give 2 grams 8 hourly, so 6 grams a day as opposed to 4 grams a day. If you're not giving it optimally, you don't actually improve your PKPD target attainment. So we asked the program to simulate an exposure, and you can see here that what we decided to do was to do 2 grams of meropenem every 6 hours as a 4-hour infusion. This still had us having quite low-ish exposures, but we did have about, using the dosing simulation software, it showed that we had about 83% reaching of the MIC and a peak concentration of around 8 milligrams per litre. But you can see the way the dosing software shows you that the concentration exposure parameters change. So you bring your peaks down, you keep above the MIC for longer by giving them less time to clear it. So this was quite reassuring. It's what we went with. And just to show that all models are wrong, but some models are useful, we gave the 2 grams 6 hourly over 4 hours, expecting to get a level of, just below 2 and about a level of 16. Because lots of things change. The dosing simulation was really taking the information that it's got at the time to give you a prediction. And then in the meantime, there can be drug interactions, there could be changes in renal function. So I think one of the best things you can do when you're doing your dosing software is use it to nudge you in the right direction, but always keeping it within the parameters of what you think is the safe dose. And then rechecking as time goes by and adding that information back into your model or your dosing software, and then helping improve what it predicts in the future. Just really quickly, we haven't talked a lot about this today, but this is something that we also talk about all the time. Just when we're talking about our targets, I think it's really important when we're doing TDN and using that in terms of dosing software, that we've got sort of 3 targets in line for antibiotics or antimicrobials. One is effectiveness, so making sure we're giving enough and in the right manner to optimize the PK/PD parameters that correlate with effectiveness. Trying to minimize toxicity, so whatever that looks like, either bringing your peak concentrations down or decreasing your AUC. But also in the antimicrobials, there's a limit that's associated with resistance suppression. And so just to be having those sort of coming into your mind as well. Oh, I should note, I could put a screenshot here. I did write a TDN guideline when I was the high DSO, and it's freely available on the internet. And we talk about effectiveness and toxicity targets for beta-lactams, linezolid, antifungals, and ganciclovir. And then for resistance suppression, there are targets that are associated with decreased generation of antimicrobial resistance. The way I think about it, I guess, is if you're sort of using your antibiotic to achieve a drug concentration that surrounds the MIC of the pathogen, then you might be selecting out those pathogens that have an MIC of 1, 2, or 3-fold higher. But obviously, if you're dosing to be 4 times above the MIC, then you're more likely to wipe out some of those intermediate range pathogens as well. All right, so back to our case, this guy also got vancomycin, so sort of 100% vancomycin from the talks tonight, which is what everyone wants when they come to a Thursday night session. Just lots of chat about vancomycin. So we have a dose cap of 3 grams implemented really throughout Brisbane, I would say. So Mr. TD got a 3-gram loading dose and then was started on 1.75 grams BD. And he had a concentration for the 4th dose. So he had a sample taken for vancomycin concentration, and his concentration was 8. So it was increased to 2 grams BD, and his concentration remained at 8. So I think when you've only got the dosing concentration, you don't have the software to add to it, there's a few things that you might suspect is happening here. You might suspect that he's subtherapeutic and that his concentration hasn't changed. But what I found really interesting was once I put him into IDODS, it sort of became much more clear to me, and actually there was sort of a lot going on with this vancomycin that I found really interesting. So again, this is another graph from IDODS with simulated total concentration of vancomycin on the y-axis and then time on the x-axis. So you can see he got that nice big loading dose, and then it only drops to a drop of about 15 before he got his first maintenance dose. So they gave the loading dose later than was charted, and they gave the first maintenance dose on time. So for the first 24 hours, he was actually quite therapeutic. He had an AUC, 24-hour AUC of 525.9. We assume that the MIC was 1. So he actually was therapeutic for the first 24 hours, even though if you just saw that 8, people would suspect he had been subtherapeutic the whole time. So that's really reassuring. And then you can see that his maintenance dose wasn't enough to keep him at that nice high trough. So it did start to drop over time. You can see the first level of 8 there before the 4th dose. And even though it looks like the concentration stayed the same because it was 8 and 8, you can see it actually dropped before it came back up to 8 with the 2-gram dose that he got. So anyway, again, just, it's really interesting to look at these dosing softwares, but regardless, he was subtherapeutic with an AUC of 358. And then he was switched over to a 5-gram continuous infusion, which the dosing software suggested it would give us a concentration of about 20 and an AUC of 480. His concentration is actually a little bit higher than that, but he's done really well at continuous infusion, as people tend to do. He did have slightly higher concentrations than what was predicted. What's also nice about looking at this is just thinking about when you're switching from intermittent infusions to continuous infusions. If you can start a continuous infusion halfway through the dosing interval, you don't have that big dip and then the slow rise again. That's really obvious on the graph here. If you do a picture halfway through the dosing interval and start with continuous infusion, then you won't have that period of being subtherapeutic. And this is a new case now. This is a patient who wasn't in the ICU, but it's talking about ICU, isn't it? He was in the ICU probably. So he was a 49-year-old who had gram-negative bacilli in blood culture. He had not an elevated creatinine, creatinine of 76, creatinine clearance of 135 mils a minute. And no, he wasn't in the ICU, otherwise he would have been ordered by 8 hourly for TAS. So apologies. But anyway, he got a dose of 4.5 grams IV 8 hourly as a 30-minute push, which is our standard of care, whether it should be, but is our standard at the moment. So again, you can see graphing here. The red dotted line towards the bottom of the graph is the MIC. So what you really want is that your black concentration line is above the red line for the whole dosing interval. You can see that at 4.5 grams, 8 hours of 30-minute infusion, you're only 60% of the time when you're above the MIC. Even increasing it to 6 hourly and keeping that 30-minute push, still you're only 80% of MIC. And this is for an MIC of 8, where in the next slide, I brought the MIC line up to 16, which is what the cutoff for PIP-TAS is to Pseudomonas. And you can see that first graph is still at 4.5 gram, 6 hourly. So you're barely even above the MIC for 50% of the dosing interval. And then without needing to increase the dose, just taking that piperacillin to 4.5 grams, 6 hourly over 4 hours gives you 100% tube of MIC for an MIC of 8 and 91% for a tube of MIC for an MIC of 16. So really knowing how to use your drugs to get the most out of it and using the dosing simulations that help you visualize it and plan it. I don't speak Latin, so I would call this dose forecasting, which is before you've done TDM, but Paul and Sebastian have both described this beautifully already. So this is a 32-year-old BG who was another motor vehicle accident with multiple injuries, intubated and ventilated in the ICU. After 48 hours, he had fever, he was desaturating and had increased sputum production. He was growing a Klebsiella pneumoniae from a sample from his endotracheal aspirate. He's 180 centimetres, 90 kilos, and a creatinine of 69. The UCAS breakpoint for the Klebsiella is 8. And so the question was, should he start on 4.5 grams IV 8 hourly? I mean, no. 6 hourly, should he have a prolonged infusion or a continuous infusion? So again, I just put those details into IDODS to get a graph like this, which I guess looks a little complicated. But really, we're thinking about what the MIC of the pathogen might be. So if this is the Klebsiella, so it's an MIC of 8. So what you're looking at is the probability of target attainment, which is on the left-hand side there. And you really want a probability of target attainment in the ICU of 90% or greater, which is where the red line is. So all of the complicated little symbols that match up to the legend on the right-hand side that are above the red line can be quite useful. You can see for an MIC of 16, it's for this patient specifically. So that would be if you have pseudomonal infection. It's really only a 27-gram infusion as a continuous infusion over 24 hours that gives you a higher likelihood of achieving 100% T of MIC. But what is really interesting, again, is just matching up your PK/PD parameters and then your likelihood of target attainment. So you can see here that 3.375 grams, it's not available in Australia, but it is available internationally, given 6 hourly, given 8 hourly over 4 hours, outperforms 4.5 grams given 6 hourly as a 30-minute bolus. And that's because we're not optimizing the way that we're giving it to make sure we're having a much higher above MIC. But you can see that 4.5 grams 8 hourly over 4 hours actually does give us 90% probability of target attainment. So it's not that the 8 hourly dose is no good, it's actually that the bolus is the problem more than the 8 hourly frequency. I don't know if that's the wrong thing to say, but I find it really interesting. It gets me thinking a lot about if you know how your drug should work, and you can think about how you should give it to make sure it does. Okay, so that's going through quite quickly, but in summary, dosing software is a very, very valuable addition to what I otherwise do, which is guesswork for drug dosing. It does need clinical interpretation, but the use of dosing software can nudge you to the higher or lower end of the dose. I do think you can sometimes get recommended quite sort of outrageous doses or things. You need to always be rechecking once you've made a recommendation and keep it within the safe limits of the drug. Know the limitations of the software, as we've mentioned already. You still need to adapt to changes in the patient's orbit function, potential drug interactions or signs of toxicity, and just remember what you've told the software is what it's using to make its decisions. And you can have a lot of fun with it. That's it.
Thank you, Eddie. That was fantastic. Went through some really interesting cases that are very clinically relevant. And I'm sure there are other participants out there who can lean on those cases in their own clinical practice of how they might use it to inform using dosing software if they have those available. And Eddie's already sticking around for some questions, so please fire any clinical questions away. She's very good at those. She does it on a daily basis.